So in these kind of situations, you have to load the patient with steroids and local as well as systemic. General condition of the patient is seen if a patient has multiple organ disease, if he has renal transplant or kidney patient, you are on the side of infection. Also, a good clinical history is taken from the surgeon, whether any complication was there during surgery or not. If there was any complication, that means it's a post-op reaction rather than an infective etiology. Patient of infection usually comes with a typical complaint. डॉक्टर साहब कल तक तो मैं ठीक देख रहा था, पर रात को सडनली आई वोक अप, मेरे सर में दर्द हुआ और मैंने एक आंख बंद करके देखी तो मेरे को दिखना बंद हो गया. If the patient comes with this history, the spot diagnosis is infection, and you have to take this patient for intravitreal injections. But this cardinal sign of pain is only there in 70% of cases, not all patients. Uh, you have to look at vision. If the vision is good, then usually the infection, the reaction is sterile. But if the vision is poor and there is a sudden drop in vision, are on the side of infection. If you have an angry looking eye, severely congested with pain, you are on the side of infection and a diagnosis of infection is made. Intraocular pressure is usually high in sterile inflammation in lesions like in disease like TAS, and low in infective disease because of the severe inflammation. The IOP will be low. Then a careful examination of the wound integrity is done. If you see a weak wound, phaco burns, vitreous in the wound, if you see an exudate in the wound, blebitis, the diagnosis is infection, and you go ahead and give intravitreal injections. Hypopion means there is a severe inflammation in the eye. The reaction is 4 plus, and because of the 4 plus reaction, there is a deposition of these macrophages. And if you have a dark brown hypopion, then it's a sterile. Yellow or white hypopion is usually infective. Important thing, if you have an hypopion in your patient, you don't have to let this patient go. Make this patient sit in your OPD and monitor it every 2 hours. Ask your OPD attendant to dilate the patient, put antibiotic drops and steroid drops hourly, and still you see this hypopion is progressive, then it should be considered infective. Pupillary dilatation, according to me, is one of the most important signs to decide whether it's a sterile inflammation or it's an infective inflammation. Uh, what you have to do if the usually patient comes with a constricted pupil, you ask your attendant to put dilating drops at every 15 minutes. Even you can give subconjunctival midricaine. If you are able to break this fibrin membranes or dilate, you can see peep into the retina and you will be able to diagnose whether it's an infective or an inflammatory pathology. But if this pupil does not dilate, then err on the side of infection and give intravitreal injections. If you have an absent glow, that means it's an infective, or if you see any signs of exudates in the vitreous cavity, it's an infective and it's clear-cut signal for you. Go ahead and treat this patient as infective. In sterile inflammation, the glow is good. Many times, once you are not able to diagnose, peep into the retina, whether the retina is good or you are not able to see the vitreous, then you will have to do an ultrasound. And if you see exudates like this in the vitreous cavity, the diagnosis is spot on infective. TAS is usually presents within 12 to 24 hours. There is a severe corneal edema, that is limbus to limbus. There is a dilated pupil. AC reaction is moderate to severe. There is an high intraocular pressure, and the disease is restricted to the anterior segment. Usually, the cause of TAS is reactions to abnormal solutions, contamination of equipment, denaturated viscoelastic, residual detergents, intracameral anesthetic agents, preservative in topical medication. But 90% we are still not able to find out what is the cause of TAS. And if you have it suspicion of TAS, then patient is put on hourly topical steroid under daily supervision, and IOP is monitored, and you will start seeing improvement within 24 to 48 hours. If you don't find any improvement within 12 to 24 hours, then think of infective etiology, don't think of TAS. We'll see some examples here. This is one of the patients. You can see RK has been done. 1 day post-op, there is a very severe fibrinoid reaction. It is, but no hypopion. We started this patient on hourly steroid. Day 2, you can see there is a retraction of the fibrin membrane. Day 5, the fibrin membrane has retracted. And day 14, the eye is absolutely quiet, and the patient comes with 6/6 vision. This is one of the patient. You can see there is an hypopion. We gave intravitreal injection of vancomycin and ceftazidime. The hypopion disappears by day 5. And generally these patients, we start with systemic steroid once the hypopion disappears. And you can see day 10, the pupil is dilated. You can see a good fundal glow. And this patient also improved with a very good vision. This is an interesting patient. You can see almost a quiet anterior segment. There is no reaction. But why I wanted to show this patient is there's no glow. Next day, 1 day post-op, this patient came with a finger count vision. We examined the preoperative records. The vision of the patient was 618 preoperatively. So once you don't have a fundal glow, that what I said before, the diagnosis is spot on, that is infective. Immediately we took the patient to operation theater. Here you have to decide, a decision has to be taken of intravitreal injection immediately, because if you delay this patients will land up with vitreous surgery. So we gave intravitreal injections of vanco and ceftazidime, and you can see within 20 days you can see 6/6 vision. Anterior and the posterior segments are good. This patient, we gave intravitreal, but patient didn't responded. So we went ahead and did an IOL explantation with a base dissection, and these are the post-operative results with 624 vision, and we were able to salvage this eye. Uh, Coming to chronic endophthalmitis, this patient, if you see here, you can see whitish deposition on the posterior capsule, had incidence of recurrent inflammation. Each inflammation used to subside with steroids and posterior subtricot, but it bounced back the moment the effect of steroid decreases. It bounced back with vengeance. And after 4 to 5 inflammation, we saw the posterior capsule, and we realized this is not simple inflammation. This is P. acne infection. And for P. acne infection, you have to remove the IOL with capsule, and we did the same, and the patient is having 6/6 vision. After 6 months, we took the patient again for surgery, did scleral fixated IOL, and patient now is enjoying with 6/6 vision with glasses. Uh, in fungal endophthalmitis, if you see this cotton ball opacities with vitreous haze, the eye is relatively quiet in fungal endophthalmitis. And these cotton ball opacities, the diagnosis, what you get is candida infection. And these patients will not benefit with intravitreal injections. You will have to give intravitreal voriconazole, that is Voritech, followed by a vitreous surgery. because these patient requires multiple injections. One injections will not benefit this patient. The, even with all this information, many a times there are patients we are not able to decide whether this is infection or inflammation. So what we do is, in doubt of excessive inflammation, start intensive therapy with steroids, antibiotics. Antibiotics you have to choose gram negative and gram positive. So we start with moxifloxacin with concentrated tobacin. Nowadays we are starting with vancomycin drops. With cycloplegics, usually atropine with tropicamide is preferred. Homide does not dilate the pupil. And other important thing, you have to follow these patients every 2 hours, 3 hours. You cannot let this patient go home and say you come tomorrow and then I'll decide what you have to do. You have to admit, because all our practices are daycare practices. You have to, generally we see our patients in the morning. You make the patient sit in the OPD and ask for hourly drops, and a very close follow-up is done. If it is a pure inflammation, it starts showing signs of improvement within 24 to 48 hours. If infection improvement does not occur, or sometimes small initial improvement and then worsening, you have to consider intravitreal injections. This is a chart of what I have summarized before. If you have pain, that means infection. Surgical manipulation, that is a sterile, you have to give steroids. Weak wound, chances of infections are more. If hypopyon is there, white hypopyon means inflammation, means infection. Brownish hypopyon means uh, in, inflammation. Pupil is poorly dilating, goes in favor of infection. If you have these last two signs are mandatory to determine whether it's infective or inflammatory. If you see no glow or exudates in the vitreous cavity, don't err on the side of inflammation. It's infective, and you have to take the patient to operation theater and give intravitreal antibiotic. So, take home message is sudden deterioration, bad wound, pain, chemosis, hypopyon, poor glow with exudates in the vitreous cavity. Think of infective etiology, give intravitreal. If there is a pre-existing disease, surgical manipulation, complicated surgery, hypopyon, good glow, eco-free ultrasound, usually it's sterile and you give steroids. Uh, After giving intravitreal injections, watch for 24 to 36 hours. If there is an improvement, continue with medical treatment. The moment the hypopyon goes, start your patient on systemic steroids, and after that stage, the systemic steroids starts improving the vision, not the topical steroids. If there is no worsening, continue with the medical treatment, and after a while you see there is no significant improvement, go for a pars plana vitrectomy. If there is a worsening on 24 to 36 hours, take the patient for pars plana vitrectomy with silicone oil. So to conclude, careful history from both patient and surgeon, along with close follow-up and timely intervention, can salvage most of the eye. Thank you very much.
Thank you, Dr. Avnindra. So you covered the subject very well. So you included everything. I have a couple of questions from the general ophthalmologist perspective. What is the role of systemic steroids? So very often we see prescriptions with systemic steroid apart from the topical medications.
Sir, first the infection should be taken care by intravitreal antibiotics. Once you are sure that infection has gone, then only you have to start with systemic steroid. Because there are two parts to endophthalmitis. One is infective, second is the reaction to the endotoxins. Infective part will be taken care with the intravitreal antibiotic. So there are two views into it. Many people give intravitreal decadron, but as a preference, as a group, we don't go for intravitreal decadron at first sitting. Once the inflammation subsides, by second to third day, we start the patient on systemic steroids, and provided the hypopyon is not increasing and the patient is not worsening, and then the systemic steroids improves the patient, because then the inflammation parts comes where the endotoxins and the inflammation due to the bacteria are there, which is taken care by the systemic steroids.
Yeah, thank you. And yeah,
What is sir's recommendation? Would he prefer methylprednisolone oral or Vizolone in his opinion?
We prefer to give an oral prednisolone, Vizolone only.
Not methyl.
No, we don't give. No, no.
We give oral.
Actually, if you see, you have to titer methylprednisolone, because if you see the doses of methylprednisolone and
16 milligrams, 8
very high.
milligrams.
so the calculation what it comes is zero point 0.4. If you 10 milligram is equivalent to 0.4 milligram of 4 milligram of methylprednisolone. So you can equally calculate methylprednisolone. If you see the pharmacokinetics, it breaks up into prednisolone only, and the results are almost the same.
Okay. One more thing, see, most of us are daycare center, we ask the patient to, some surgeons ask the patient to come on the next day and some on the 5th day. So what would be the preferred? How can you detect the cases early, and which would be your approach for the first or second post-operative visit?
So one day is mandatory. I think nobody is practicing the second day on if you operate. One day is mandatory. Then you tell your patient if there is a history of pain, congestion, or sudden decrease in vision. I think every surgeon has a note कि if you see any history of pain, sudden decrease in vision, you have to immediately report to the OPT.
Thank you. I think that is very important, because when and how to obtain urgent care, because in the night we may not be available. So we have
But
to
the only caveat
counsel
is
the
that,
patient
don't
properly.
do a telephonic kind of consultation.
Yeah.
If patient has issues, we write SOS, please, then patient should rush. Patient should immediately come. If there is, we write on the discharge card, if you have pain, excessive, watering, or, vision loss, then report immediately. Although you see most of the endophthalmitis come between 1 and 3 days, or 2 and 5 days in fact. So like Nirmal was asking, first day you have seen, then you call patient maybe after a week or so, you can miss in between. So therefore you have to write, please report SOS in case of 3-4 things. Yeah?
May I ask?
Yeah, please.
So, one of our patients, he had not very significant visual improvement post-operatively, initially like up till 10 to 15 days. So, we were expecting that refractive error and like 1 or 2 line improvement was there afterwards, but it was not improving very significantly. So, afterwards we like dilated him and we saw that there was some part of cortex was there. So, we went for a secondary cortical aspiration, and after that the patient had
Infection.
initially first day he had good vision and everything. After 2 days he did not even have that much pain, but he just suggested that I am having lesser vision. He just complained that yesterday I had, probably he didn't have any trauma also, nothing was there, but he just said that vision is somehow a bit less comparatively, as he felt.
So what is your question?
So the question is that only that he might, like when we took the tap and everything, so P acne came. So that would have been like when the secondary intervention would have been done, then it would have been released, like the
See-
exudates are also there.
Yeah, the nidus would have been,
Yeah.
Sir, please.
Yeah. Yes, Nirmal.
yeah, the nidus would have been there during the first surgery, and the second procedure probably aggravated that.
Yeah, that's a reasonably. You see, P. acne sometimes I have
the
seen
capsule.
normal patient. Yeah, because the nidus is generally in the capsule or around that area. Sometimes we have done YAG and gets precipitated. Like in your patient, most likely the nidus was there. You did the second intervention and it got precipitated. So most likely that is the reason. So in the such situations, you have to act vigorously because its response to Vanco pretty okay. Because Vanco is the vancomycin, he will respond. Yeah.
You give intracameral moxifloxacin during the second procedure.
So that is, yeah, we'll talk about